I got to the point where I thought, I should be really happy. I've ticked all these boxes on where I want to be. I've finished all my training. But I got home, I was absolutely miserable. For esophageal cancer, when a patient gets referred to us, they've got a 50% chance of already having disease that's spread, which means they get palliative treatment. So we can't cure them. They're going to die from that. The area that I went into when I came back was all in artificial intelligence in surgery, which was really in its infancy back then. He said, reach out to my EA, and the email address was nasa.gov. I thought, wow, this looks legit. So I messaged and I managed to get a one-on-one Teams interview with him. He's been back in Kenya for probably 5 months now. He's already done 50 operations using the skills he's learned in Melbourne over there. So he's already having a huge impact. I got threatened with military prison during a first aid lesson of all things. And he didn't like the fact that I was challenging him and he threatened to put me in jail. So I soon learnt my lesson. Historically, training was basically you see one, then you do one, then you teach one. And you're doing it on real people. At some point, you need to question it. But it's really hard to conduct trials in surgery. At the moment, the quality of life for a lot of the patients with the conditions we treat is really poor. So there's lots of work that needs to be done. Hi, I'm Dr. Matthew Reid, and this is the Good People Podcast.
It's a tip of the cap, it's a pat on the back, it's a smile from ear to ear. They're the good people from round here.
Yes, welcome to another episode of the Good People Podcast. My name is Andy and it's brought to you by In Other Good News, recorded here in the In Other Good News studios. And if you're watching this, you'll notice that I'm in a different outfit to usual today, and that is in honour of my guest who has been so generous with his time to squeeze us in between some very important work. His name is Dr. Matthew Reid. He is a surgeon at the St Vincent's Hospital in Melbourne. He's a younger fellow representative on the Academic Surgical Committee at Royal Australasian College of Surgeons. He's got a PhD. He's ventured all across the world in pursuit of academic excellence. He's a board member of the Hope Fund, and he has a list of awards as long as your arm. Dr. Matthew Reid, welcome to the podcast.
Oh, thanks, Andy. Thanks for the invitation. It's great being here.
It's a pleasure to have you here. What if I can throw you under the bus, though, straight away, right at the top of the interview? You, as for a career, as a job, on a daily basis, perform surgery on people, which can be life and death outcomes. Mm-hmm. But you have nerves on coming onto a podcast, and I find that quite amusing.
Oh, I'm certainly quite nervous. Yeah, I've never done anything on TV or podcasts, so yeah, this is a first. So.
I imagine you're going to be on TV and podcasts a lot in the future, and I'm going to explain to our to our listeners why, because you're doing some amazing things. So welcome to the podcast.
Thank you.
We're going to have a little bit of a chat about what you're doing currently and then the stuff that you're aiming for in the future. You're currently a surgeon.
Correct.
At St Vincent's. Mm-hmm. You specialise in upper gastrointestinal surgery.
Yep.
Which is some unfortunate things, some cancers and things, but it's also other things, isn't it?
Yeah, it is. So my specialty focuses on the esophagus, which is the food pipe, and the stomach mainly, as well as general surgery. So we do sort of operate on the bowel and the liver and the gallbladder and things like that. But predominantly my subspecialty field is the esophagus and stomach, and we operate on cancer and things like reflux and hiatus hernias. That's when the stomach sort of ends up in the chest. Should be in the abdomen, but sometimes it pops up into the chest. Uh-huh. And we even do things like weight loss surgery called bariatric surgery. So that's actually quite rewarding, helping patients lose weight, getting down to a healthy weight range, and really improves their quality of life. So the cancer work is, that's quite intense and can be really stressful. And unfortunately, the diseases that we treat, the outcomes universally are quite poor. So even when you've done your best and you think you've cured someone, there still is a chance of cancer coming back. And, quite often we're telling patients bad news, such as, I had an example last night having to tell somebody some bad news. but it gives it a bit of a balance. So, the weight loss side of things, it is a lot more positive out of it. Yeah.
Yeah, you get some.
Yeah.
You get the people are probably a little bit happier from the weight loss outcomes than
certainly.
they are with the cancer side of things.
Yeah.
All very important though. All very important things. Now you specialise in this area. You can't. Not all surgeons specialise in this, do they? So you've had to go and do extra study to be a
So
specialist in this
the
area.
path I took, I decided to become a surgeon. I wanted to become a general surgeon. And when you train, the training body is the Royal Australasian College of Surgeons. So at the end of that 5-year sort of fellowship program, you sit an exam, and if you pass that, they call it the quiz, but it's a bit more than a quiz. It's sort of 3 days of really intense sort of examination. If you pass that, you become a general surgeon, which means you're qualified to do a little bit of everything, but you're not super specialised in any one area. And then if you want to focus on something more, then you usually do another 2 or 3 years of extra training on top. And for me, that was another couple of years in Melbourne, and then I took my family overseas and we lived in the Netherlands for a period and did some work on esophageal cancer, but mainly using robotic surgery, using the robot to help with the surgery.
Yeah, that's crazy stuff. And the advancements are really exciting. And we're going to touch on that a little bit later on some of the stuff you've been working on. Can I hit you with a couple of audience created questions here?
Yeah,
I did ask around. I said, what would you want to ask a surgeon? Number one, have you ever been afraid of blood?
Not so much blood, but when I was a medical student, the only time I've ever felt like almost passing out was watching the tourniquet go on someone and just having it was there for about 5 minutes and the arm just sort of swelled up. And that's the only time I felt queasy as a medical student.
That's what made
so
you
not
queasy?
the blood, it's just watching the tourniquet go on for some reason.
Oh.
So it was weird, but that's the only time it's happened.
It is a little
But
strange.
I've certainly seen a lot of blood. Some of the traumas that you have or patients come in bleeding, like some patients have bled 10, 15, 20 litres of blood. And you've only got 5 litres of blood in your body. So that's that whole volume like 4 or 5 times.
Yeah, right.
So
The next question was, what was the strangest thing you've ever removed from a person?
I don't think I can say it on the Good People podcast. You don't
Well, it probably gives us an indication of where you removed it from then, I guess. Well, there you go. There you go. Now I'm intrigued. We'll discuss that one after the show. And the last one was, what's the hardest part of the body to do surgery on?
Well, for me, it's probably the esophagus, and that's why I chose it, because of the challenge. Just anatomically and physiologically, there's so many things to sort of factor in. And if you get it wrong, the consequences are quite devastating. So there's a lot of pressure, operating on that area. You're against some really sort of major anatomical structures in the body. So if you veer off course, even by a couple of millimeters, you can be into some big sort of blood vessels.
Oh, yeah.
So-
I guess you've got some pretty major stuff.
Because you're operating, you're right on the heart. So all the blood returning to the heart is sort of, and the heart being pumped out by the heart is right next to the esophagus. So-
Is it all down through the throat? That sort of...
No, so this is, operating we make an incision through the
ribs.
ribs or sort of keyhole surgery through the ribs.
Yeah.
But
okay.
yeah, we're operating in the chest, usually on the outside of the esophagus.
I see.
Yeah.
Um,
So we're removing that segment and then reconstructing. So then you've got to pull up another organ like the stomach, turn that into a tube and pull it up into the chest and then sew it to the bottom end of that esophagus that you've divided.
You said to me recently that there's a lot of science obviously involved in surgery, but there's also it's an art form. You said,
Yeah, and I said that because people think that everything we do in medicine has high quality evidence behind it, and that's why we do the things we do. But when you look into the history of things and how decisions and sort of treatment pathways came about, there's not actually a lot of high quality evidence behind it, and a lot of it's just expert opinion and what people have just done. So you continue doing what the people taught you did, and at some point you need to question it. But it's really hard to conduct trials in surgery, because I guess everything's so algorithm based. So if you come in with a problem, you almost know exactly what's going to happen and what should happen. So to think outside the box takes quite a bit.
Yeah. And I guess there's not a lot of margin for error. You can't just go and try something new, I guess.
Well,
without-
exactly. So if you do something and the outcome's suboptimal or there's a complication, then it's really hard to justify.
Yeah.
Yeah.
Now I'm going to be not correcting your language, but hoping to dumb it down a little bit for people such as myself, because I do notice that you guys use a lot of big words, even in the introduction.
Yeah, which word?
I mean, fellow's an interesting word because for me, a fellow is a bloke I met down the street.
Yeah, yeah.
But for you guys, that's an important thing.
Yeah, and it's interesting they still use that because probably 2 years ago the college got rid of gender-based terms. So traditionally we used to be Mr. and Mrs., but now we're doctor.
Right.
So, but they've kept the fellow. So fellow just means that you've become a member of the college. I guess historically it's gender-based, but that is still, I guess, something, a legacy sort of term that's hung around. And the reason why surgeons were Mr. is because the profession sort of began from the barber industry. So the barbers were the first surgeons.
Wow.
True story.
So
You've gone silent.
I have. I'm waiting for more. I'm waiting for where.
No, well, historically they were the ones with a scalpel, and could sterilize things. So if people, had an injury or a foreign body, like something stuck in their, in a part of their body that needed removing, they'd go to a barber.
Go to the barber.
Yeah. So that's why a surgeon was a mister. So it's not because they've done less training. They're still a doctor, but yeah.
I have always wondered that because you go from a mister into a doctor, and then it seems like you take a step back when you.
Well, you go from a doctor to a mister.
Yeah. And you go back to a mister.
Yeah,
which is,
but it comes from the
a
origin
barber.
of being a barber.
That's unreal. Oh, I've learnt something today. There you go.
Yeah. Don't get me to cut hair though. I did that during COVID. Wasn't good.
What, your kids' hair?
The whole street.
You cut your street's hair?
Yeah, every kid on the street.
Was that so? This feels like a reversal.
Yeah, going back to the barber
surgeon
days.
goes back. Now, I've got here, like I said, you've got a substantial amount of awards here, and I'm not going to list them all. But in 2021, you got the Senior Lecturer Fellowship Award. Do you want to tell us a bit about that? You said that was probably the better one of the awards that you've won.
Well, that one's just sort of a culmination of the years of research that I've done. So when I came back from overseas, part of my role at St. Vincent's Hospital was to help with sort of further develop their research program. So this award from the College of Surgeons just gave me, that support I needed to establish that program. So it was a sort of funding for 2 years to sort of get that program up and running. So, in order to get that award, you need a bit of a track record and a commitment to sort of pursue research. And the area that I went into when I came back was all in artificial intelligence in surgery, which was really in its infancy back then. But we've really done some good work in that area and sort of become leaders in that field. So,
what advantages are there with artificial intelligence in surgery?
Well, none at present, but we're trying to develop the tools so that we can start using them. And one of the areas we're focusing on is to try and develop a tool that can help sort of warn surgeons or prevent them from sort of causing complications. So if there's key structures, really important things that you don't want to damage, so we want sort of the surgeons to get a warning if they're veering off track, because sometimes surgeons, they sort of get tunnel vision and they're telling themselves they're operating somewhere when in actual fact they're in completely the wrong area. So even if an experienced surgeon can end up in that position. So we're just trying to develop an additional tool that can sort of just give another prompt or a warning to the surgeon to say, hang on, should you be there or maybe in a slightly different spot?
And when you say, when we're talking slightly different spot, are we talking sort of really micro?
Yeah, sometimes it's just millimeters.
Yeah.
Yeah.
Okay.
And like one area we're working on is surgery on the gallbladder. It's a very common operation to have your gallbladder removed. Like about 40,000 operations happen a year in Australia.
Is that right?
But one of the complications is damaging the bile duct, which is the tube that connects the liver to the gallbladder to the bowel. If that gets injured, you end up taking 10 years off somebody's life.
Is that right?
Yeah. So it's a big deal.
So that's you can do some good things by not
Yeah.
not affecting these.
Like the chance of it happening is quite low and remote, but if it does happen, it's got a huge impact.
Yeah, okay. And so you can reduce the chance of that with the AI potentially.
That's what we're working on, amongst other things, and a tool to help surgeons train. Because historically, training was basically you see one, then you do one, then you teach one, and you're doing it on real people. So in any other sort of profession, like being a pilot, that wouldn't happen. You're on a simulator. But we don't really have really good quality simulators in surgery. So having tools that you can use to help train would be, we think, quite beneficial.
Yeah, it would be. Now, you've got a PhD.
Yep.
What did you do your PhD in?
It was focused on cancer biology, so trying to work out how cancers, tumours grow. And specifically, it was on esophageal cancer, which is the organ that I operate on now, as well as the pre-cancer condition. So there's a condition called Barrett's esophagus, and that's when the lining of the esophagus changes in response to reflux. So people that get reflux or heartburn, that's probably the only known risk factor for esophageal cancer. So reflux causes inflammation, and that causes precancerous change and then cancer. So I spent 4 years in the lab basically growing tissue and cell lines, creating my own cell lines. So I worked out ways of growing tissue for up to 6 months in a lab so we could sort of work out how it grows and test new treatments on it.
When you say growing tissue, growing human tissue,
Yeah.
how do you grow human tissue?
I could send you a thesis. No, there's lots of different ways. Sometimes it's in vitro, so in plastic and certain special growth media, but it's getting the right sort of formula, the recipe. Sometimes it's actually using animals, like in mice. Mice are very commonly used in cancer research. They're specially bred so that they don't have an immune system. So when you put like cells from another organism in there, they can just grow using that blood supply and oxygen supply.
There's no resistance.
No. So yeah, there's no immunity. So in that animals, in that host. So yeah, I used those sort of types of model to grow the tissue.
Right. So you grew tissue and then wrote a thesis.
Yep.
Have I? I've done that down.
Basically, that's it. Yeah.
What-
But those models, I mean, they were sort of important in the field because when I started, there was only 3 cell lines that were really used around the world, and I produced another 3, so I sort of doubled the amount of cell lines that there were for research, which led to some sort of collaborations overseas. So there was groups overseas that needed these models to test their new treatments. So I got to work with some really pretty cool groups overseas.
Yeah, that's pretty wild. That was, and I must mention too here, we've got a couple of other things. Like right through 2019, we've got a Peter J. Dorman Award. We've got a Cook Reserve Award. You won a Peter Ryan Prize in 2017 for Best Surgical Paper. That was on esophageal cancer.
I never won any prize until I'd hit 35.
Right.
So,
Well, it takes a while.
my kids are winning all these awards at their sport and everything. I've never achieved on the sporting field. But
You didn't get any.
no.
Becoming a surgeon is not an easy task. It took you, 21 years or something, you said?
Yeah, the whole journey from starting uni to becoming a surgeon was, close to that. Started uni in 98, and I was probably, it was 2020 when I got back from overseas. So, yeah, about that 21 years,
Yeah. And so, but you were telling me that it was probably the path you were destined to take. You hung around in your childhood. Maybe you want to tell us about how you were exposed to this sort of stuff when you were a kid.
Well, I probably started when I was about 10. I had this fascination with surgery. As a kid, I loved problem solving and fixing things. And at the same time, my mum was sort of managing a few sort of doctors' clinics and little private hospitals, birth centres. And one of the obstetricians there really became like probably an early sort of role model for me. And I just really admired sort of the work he did and thought I really wanted to become a doctor, but ultimately a surgeon. That's what really fascinated me, being able to get in there and fix things. So that sort of, I guess, sparked my interest and got me on the path. And I think also at the same time, I sort of had an aptitude for all the sort of different requirements, all the subjects that you needed.
Yep.
I loved maths and physics and that sort of stuff. So
Standard maths, physics, math, science way through high school.
Yeah, Latin and whatever else.
Yep.
Yeah.
Where'd you go to high school?
In Melbourne, Xavier College.
Okay.
In Melbourne. But growing up, I came from a military family. So when we came to Melbourne, I think I was in grade 6, and that was my 6th school. So through primary school, it was a different school every year growing up.
Wow.
Yeah.
So you travelled around a lot.
Yeah, lots of travel.
And then you, straight after high school, you got straight into medicine, didn't you? First choice, straight in.
Not exactly. It was. I really wanted to do it. It was my first preference, but I didn't get it.
Yep.
I think from memory, it's a long time ago, but I had medicine number 1. Number 2 was aerospace aviation, because if I didn't become a surgeon, I really wanted to be a fighter pilot.
Yeah, right.
Or a pilot. And so I thought there was a really cool degree where you could sort of get your pilot's license, but learn how to design a plane. So I had that number 2. It was probably harder to get into than medicine, to be honest. And then I had engineering law number 3. And I was overseas at the time when the places came out. And this is the day before internet, so I had to have a family friend on the phone in Melbourne to dial up,
the number.
call me, tell me what I'd sort of been accepted into, and then press the button to sort of accept.
Ah.
So they just had to accept regardless. But it was my 3rd preference, which was engineering law. And when I got it, I was a bit disappointed, but it only lasted a few hours, and then I'd sort of got my head around the fact I wasn't going to be a doctor, and I thought I could do engineering, but I couldn't do law. I wasn't really excited about law.
Yeah.
And then, so I went sort of 5-6 weeks thinking I was going to be starting law, and then I got a late call, a 3rd round offer to do medicine. So, yeah, I guess it was destined, but at the time you just meander your way through life, like.
Yeah, that's right.
But
and so then you took on medicine.
Yep.
And but something that I find funny, it's an interesting part of your story. You're saying you're from a military background, which answers half the question, but you were in the Army Reserves at the same time as studying medicine.
Yeah, I think it was the end of my 2nd year of uni, sort of summer holidays. I was with my best mate, and we sort of thought, what are we going to do for the summer? And we thought, let's join the Army. And we went into the city, or Vic Barracks it was, and you go through all the interviews and sort of all the physicals and medicals and all that
Aptitude
sort
testing.
of stuff. Yeah, did all that.
Yeah.
So we both did it, but then he ended up taking a job at Village Cinema at the Jam Factory, and I got into the Army. So I got shipped off to Kapooka near Wagga for 7 weeks, and it was pretty intense because that sort of initial training, it's the same if you're going full-time or part-time. You know?
Right.
So half of you are sort of full-time soldiers. So the initial 7 weeks is the same. And it was quite an experience. Like, you get off the bus. It's like the movies, like Full Metal Jacket. Like, they are just yelling at you as soon as you hit the ground. As soon as you get off, you got your head shaved.
I was going to say, did you have long hair?
I didn't have long, but, straight away I had, like, number 1.
Yep.
Yeah.
As soon as you got off.
But it was totally different culture. But I think it taught me a few things that helped with the surgical training. Sort of a lot of resilience and just sort of obeying orders. But,
discipline, I feel like.
Yeah, discipline, but it was sort of forced discipline. So that's ultimately why I think I got out. I didn't really enjoy that sort of, I don't know, lifestyle or culture.
Mm.
There's no scope to sort of challenge what you're getting told to do.
Okay, yes.
And even if you know something's wrong, you still got to do it. So, I got into trouble. I got threatened with military prison. So, during a first aid lesson of all things.
Right. You were questioning the first aid. Hold on.
Well,
you're studying medicine at the time.
Oh, yeah, I was studying medicine. So I wasn't a doctor, I was a medical student.
Right. Yeah. And you questioned the first aid.
Yeah, so we had this sergeant teaching us first aid, military first aid, like what to do in the field. And he was telling us, it's called a sucking chest wound. So you've got a wound to the chest, your lungs collapsed. Basically, he's telling us how to treat it, put this special type of dressing on, basically create a one-way valve. And he's saying it so the air can go in and the blood can go out. And I said to him, biomechanically, physiologically, it was all wrong because you want the air out so the lung can re-expand. And he's telling me, no, you want the air in because you breathe air. I said, yeah, but the air's not on the inside of the lung, it's on the outside of the lung. And he didn't like the fact that I was challenging him and he threatened to put me in jail. So I soon learnt my lesson.
And I guess you soon quit the army. Like you were
well,
forced with the decision,
I lasted 5 years. So yeah, I lasted a few years after that. But ultimately, I got out because they wanted me to do about 3 months full time, and I wouldn't have become a fully registered, a fully qualified doctor had I done that. So I had to choose between being a doctor or being a soldier.
You were sort of forced to choose.
Yeah.
Well, I'm glad you've chosen to become a doctor.
Yeah.
You're doing some great work, and you've moved on from there because that was 2003, was it, that you got your medical degree? Was it around then?
Yeah, going back now. Yeah, 2003, 2004, I was an intern. So your first year of being a doctor is an intern. So you're not fully registered. You're a sort of a half doctor, but you're working in the hospital under supervision.
Yep.
And then I spent sort of a few years in the hospital system doing lots of different jobs. And as I said, I knew I wanted to be a surgeon, so you have to apply to the College of Surgeons for training, but it's really hard to get onto that program. And, I applied, I think 3 or 4 times in total over about 4 or 5 years.
Is it like one intake or something per year? Or?
Well, there's one intake a year, and the success rate was probably 15-20% at the time. And, in retrospect, I wasn't a good candidate. I didn't prepare myself for it. I hadn't made myself sort of attractive to the college. To do it now, to get on, it's a lot harder. And, the junior doctor's doing a whole heap of work to get on. You've almost got to have a PhD and all these publications and really good references and be able to almost do operations independently to get on now.
Right, just to get
onto the training program. So
yeah, okay.
And then every step you go up, it's sort of a bit of a funnel or a bottleneck. It gets harder and harder. So when I got onto my further training in upper GI surgery, they take 6 candidates for all of Australia and New Zealand each year. So every level gets a bit harder. And then you get to the end and you need a job. And there's basically no jobs in the public health system. They're all full. So the next hurdle is really finding a job in the public health.
Yeah, right. Yeah. So you go through all of that to then not have too many career opportunities. Australia has a lot of surgeons. The surgeon per capita is high, isn't it? I think I saw recently on a video you shared.
Yeah. Compared to other areas where I work, we are certainly very privileged in Australia. We've got a lot of specialists. If you need urgent surgery, you get it straight away. We've got a good public system where everyone gets free healthcare. We've got a private system where people can access and choose their surgeon and their hospital. So we compared to like in Africa, in sub-Saharan Africa, in Kenya, where I've had the opportunity to visit and work, they're one surgeon for 15 million people. So trying to actually access quality healthcare is almost impossible.
Yeah, and actually that's a really great segue because something I wanted to ask you about was global health. Mm-hmm. I know that you're into global health. Mm-hmm. Do you want to maybe explain what that means to you? And then I guess what's the draw? Like why are you drawn to doing that kind of work?
For me, global health is practicing medicine outside of my own community, basically. And more so in the developing world. And I had this invitation to go to Kenya and help them with their training and to teach them some new techniques. So I took that on board, and in that process brought one of their newly graduated surgeons to Melbourne for 12 months. So he trained with us at St. Vincent's. He's been back in Kenya for probably 5 months now. He's already done 50 operations using the skills he's learnt in Melbourne over there. So he's already having a huge impact. But that it came about basically because I got to know one of the surgeons over there, Professor Russell White. He basically built this hospital and set up the surgical training program for 6 of the sub-Saharan countries. And I invited him out to speak at one of our conferences recently, and he agreed to, but at the same time he said, would you be able to train, some of our surgeons? And I agreed to do it, thinking it was a great cause. So I went over there, took my family over, just sort of experienced firsthand sort of the stuff that they have to deal with. And when you see that, you're just blown away, the discrepancy between the quality of, the healthcare systems and what they have to sort of deal with and how they have to improvise, basically.
Yeah.
Like you're doing ward rounds and you're seeing 16-year-old kids that are just going to die unless they get their heart valve repaired because rheumatic heart disease is such a big thing over there.
There's some pretty ordinary stats, isn't there, around where the illnesses present versus the ability to treat them.
Yeah.
I think I read down. Actually, I wrote it down somewhere. There's like something like 6% of the world's surgeries conducted on 33% of the world's population, something along those lines, which is pretty amazing sort of.
Yeah. I mean, there's all these disparities. So, you can be oblivious to that and just be in your own little silo, work in your own little community. But when you do travel and actually, experience what it's like in these different sort of populations, you're sort of drawn to it and you want to sort of contribute and help. So
Yeah.
that's where that sort of, I guess, interest in global health came about.
Just Kenya have some unique health issues?
Well, they've got the rheumatic heart disease, so that's after you get an infection like a strep throat, and then it causes damage to the heart valve.
Right.
And then the heart's a pump; it needs to pump the blood around the body. But when the valve's leaky, it doesn't pump effectively, so they end up with heart failure. So as I said, you're seeing kids that should be at the prime of their life, 16, 17, and they can't even walk 10 meters without having to stop for a rest.
Yeah.
But also esophageal cancer. So in Australia, esophageal cancer mainly affects people in their 60s and 70s. But in sub-Saharan Africa, you've got this pediatric population that get it. Like they've operated on children as young as 11 with esophageal cancer, which we just don't see, and even lots in their 20s as well. So it's a different disease, and but they still need to be treated.
Yeah, and they don't have the accessibility. Like they don't have the access to the surgeons.
Exactly.
Like I say that we have here. There's a ratio I saw quoted about the predicted effective number, or if you have this many surgeons per 100,000 people, that's the
minimum requirement.
Yeah, which we are more than we
Probably
need.
the World Health Organization puts that number out.
Yeah, and we're above that, well above that.
Well above.
Whereas somewhere like in the sub-Saharan areas, they have very few surgeons per 100,000 people. So this is what you're working towards, right?
So if you're thinking about something like esophageal cancer, in Melbourne, you've probably got one surgeon per 100,000 people that could operate or treat that condition. Mm-hmm. Whereas in Kenya, it's one surgeon for 15 million people. And they're getting the cancer at 5 times the rate. So in Australia, maybe 1 in 25,000 people will end up with esophageal cancer. In Kenya, it's 1 in 5,000. So
yeah, it's pretty horrific.
So when you do those sums, it's a massive discrepancy. Yeah.
And so what you're doing is helping to train. Well, you mentioned the one surgeon that you've been training.
Yep.
But the plan is to impact that much greater, right?
Yeah. So it's all about what we're trying to do is build capacity. Yeah. So we're teaching them some skills, but also helping to build, I guess, their unit structure so that they can continue to grow on their own. So both from a clinical aspect and a research aspect, because there's lots of unanswered questions over there. So they need the skills to be able to sort of do research into those areas and work out how they can improve their services as well. And part of that is also providing ongoing support. So we've already linked in, so when they have complex cases, they can present them to our panel of experts in Melbourne, for instance, and they've started doing that. But we're also, in the near future, going to have this sort of remote surgery where we can sort of have a real-time supervision on what they're doing in the operating theatre. So we can actually guide them as they're operating with the complex cases. So that's what we're in the process of setting up at the moment.
Now, this is the technology. Do you want to tell us about the technology?
Yeah, well, the technology is pretty neat. It's almost like wearing the Google glasses. So the surgeon operating in Kenya wears a headset. It's got a camera on it. And almost like a fighter pilot, it's got a head-up display. So a surgeon anywhere in the world can be on their computer screen annotating, and then that field of vision that the surgeon's seeing has that annotation come up. So you can actually be guiding that surgeon. And we're doing this through the Starlink satellite network. So I've been dealing with a company in Sydney, Netlinks, who are the global distributors for the satellite network.
Starlink, yeah.
It's for Starlink, which is Elon Musk's sort of SpaceX sort of satellite
which
network.
is what you see sometimes in the sky going over. You see the trail of Starlink satellites.
Probably. I think there's a few hundred up there now.
Yeah,
But these companies have been extremely generous, providing a secure, sort of extremely fast link so we can do this in real time.
But you don't just need speed, though, do you? You need other things. You need security, right? Like you need.
Yeah, exactly. Yeah, because it's real time patient data. Yeah, you can't have any potential for it to be hacked.
Because otherwise it's compromising the data of the patient data.
Yeah, their privacy, patient privacy. That's
Yeah.
one of the key ethical principles.
Yeah.
Yeah.
I find this amazing. This is unreal. And I can't wait to see. But you're saying like there's a heap of cost involved. So you've got the internet cost, but I mean, even the pair of glasses, you were saying it's like $25,000 a pair or something.
25,000. Yeah.
Yeah. So what do you need to what do you need to progress that? What's in your
Need
way?
25,000.
Yeah.
Yeah, buy the headset. Once I've got the headset, and then we can get a proof of concept up and running.
Yep.
Then we can apply for more funding.
Yeah.
But that's the other thing that we haven't really touched on. With all the research that you do, you need funding. And funding is extremely hard to get. Like there's two big funding bodies in Australia, the MRFF, so the Medical Research Future Fund, and the NHMRC, which is the National Health and Medical Research Council. They control all the funding. But probably the success rate is about 9%. So you would put like 100 hours plus into an application for a 9% chance of having a successful award granted.
Yeah, okay.
And then if you look at the surgical applications, probably less than 2% of all funding comes from surgical units. So by and large, the majority are medical or science based. But if you're a surgeon putting an application, it's about 2% success rate. So it's hard to get the money to do the research, especially when you're the clinician treating these conditions with really poor outcomes. You want to be doing something, but it's hard to get the funding. So that's why, as a group of clinicians, we got together and we started the Hope Fund, which is our charity that raises money for diseases of what we call the upper gastrointestinal tract, so the esophagus, stomach, liver, pancreas, because these are the ones that really don't get the funding.
So now let's touch on that, the Hope Fund, because episode 21, Chris Farrell, he works with you guys.
Yep.
He's not a surgeon; he's a fake doctor. I don't know how he got through. Actually,
No.
he got through.
He's the most famous doctor on the unit. He and Dr. Carl.
Of course, Chris Farrell, episode 21. He was Dr. Rob on Neighbours, but he works with you guys. So you can have a listen to episode 21 if you want to catch his story. But I'd like to dig into that a little bit further about what. So your board is made up of highly qualified people.
Yep.
Who started an organisation to try and get more funding for what we call unsexy cancers.
Not just cancers, but all diseases affecting those organs. So even benign diseases or conditions can have a significant impact on patients' quality of life. And they're the ones that no one does any research on. So that's why we started the Hope Fund. And initially it was a group of predominantly surgeons and some nurses came on board. Over time, we're trying to bring in different sort of skill sets and expertise to the board.
Yep.
So, I think it's silly on a board to have everyone with the same sort of skill set because you need that diversity to really grow the board. So that's why having Chris come on board, he helps run the Hope Fund.
Yep.
He's been really great. He's really enthusiastic and he's done a lot for us. And he's even got us the official charity status. So we've got the deductible gift registry status.
Oh, that's good.
DGR.
Yeah.
So that's a big effort.
Which means that when
point.
someone donates to you,
they
can claim. Is that how it works?
Yeah.
Yeah.
I'm no good with money, but you get a tax deduction. Yeah, for any donation.
For the donations, which is great. So the Hope Fund, which is thehopefund.org.au from memory, I think is the website.
Yep.
Actually, I've got it right here. I'll make sure I get it right because...
I should know it. I came up with the acronym.
Oh, did you? Yeah. What's the Hope? Hope stands for something.
Yeah, it's the hepatobiliary. So that's ancient Greek for the liver and bile duct.
Right.
Esophagogastric, that's the esophagus and stomach.
Yes.
Pancreatic, that's the P. Endowment fund.
I'm not sure why you would shorten that.
No. It's a bit like the Royal Australasian College of Surgeons. No.
You guys love big words.
We do, but Hope Fund sound better. And we've got the tree of hope as the logo, which fits in with the biliary tree in the liver. So if you look at that logo, it's the anatomy within the liver with the bile duct is the trunk of the tree.
Is that what it looks like?
Yeah, that's what it looks like exactly.
Well, there you go. Oh, exactly right. Okay.
Yeah, that's it.
Well, there you go. There's
that's
some,
anatomically correct, that logo.
The tree as well. Hopefund.org.au, which you can check out some of the
the
stuff.
And it's not just research that the money goes towards. So it helps fund our cancer care nurses, our data managers, because whenever we're treating patients, you need to collect the outcome data to know what your intervention's doing for those patients and how you can improve. So, and it supports our students as well. So the money goes not just into cancer research, but all those areas.
Yeah, right. It's important too, because like you say, these are areas that traditionally in recent times aren't achieving much funding. So
No, because typically, these conditions tend to affect people in their 60s, 70s, overweight with reflux, typically male. If you're going to fund something, you tend to fund, conditions that affect other populations, I guess.
I want to move on to something else. You have reached out to the head. Now you can correct me here. He
Yeah.
works for NASA.
He's the chief medical officer at NASA.
You reached out on LinkedIn, of all places, to the chief medical officer.
LinkedIn works. It's amazing. I'm not on any social media except for LinkedIn.
LinkedIn,
And now I'm going to be on the Good People podcast.
Well, now you've tripled your reach.
Yeah,
And you reached out to him and you said, "Hey, we do similar stuff. I think let's chat."
Yeah, so I managed to get an introduction through LinkedIn, and surprise, he responded. So I got a message straight through LinkedIn, and I thought it was pretty cool. He said, "Reach out to my EA," and the email address was nasa.gov. I thought, wow, this looks legit. So I messaged, and I managed to get a one-on-one Teams interview with him. It was supposed to be half an hour, but we kept talking for 45 minutes. The purpose was to invite him to give a talk in Australia at one of our surgical conferences, because I regard NASA as real innovators, and in my role at the college, I help sort of convene some of our conferences, and I really wanted to come talk about how we can be innovators as surgeons. So during the meeting, we took the opportunity to tell him the sort of stuff that I'm working on with the remote surgery and our AI work, and that sort of, I guess, triggered his interest, because that's a lot of the stuff that NASA's interested in as well with their space exploration. So, yeah, there was a lot of, I guess, synergy there. So,
Yeah. Doing stuff at a distance. His distance just maybe a little further than yours.
A little further. So, yeah, I think they're planning to go to Mars, I think, in 2040 or something, he was saying. And I think the time for a radio signal to get from Mars back might be sort of 10 minutes or so. So it'd be pretty hard to direct someone if there was an emergency on what to do with that lag time.
Yeah, it would be. Well, especially because if you ask a question,
Yeah.
you've got a 20-minute round trip. I think,
basically. Yeah.
That might be a bit long. Well, actually, that might be a good segue, because that's going to be great to have him, if you can get him to come out and talk. That'll be amazing.
Yeah, I've just got to fit it in with their launches and landings, because they're planning to go to the moon next year. So,
Oh, right.
Yeah, he has to be at mission control for those events. So,
Well, I guess if it's the chief,
yeah,
chief medical guy.
yeah.
What sort of medical incidents are they trying to not get on a landing to the moon?
Well, maybe not so much to the moon, but I think they're thinking beyond. So there's a lot of things that they need to factor in in space medicine. So even if you just have a simple cut, like how does the bleeding stop? If blood's sort of just particles, sort of droplets floating everywhere, like it may not stop. So
Yeah. Okay.
how does the coagulate? Like in the body, you've got a special system that causes a clot to form.
Yes.
So there's lots of things that can happen in space that you need to sort of, I guess, prepare for.
Yep.
What medications do you take into space?
Yeah. Okay.
So he told me some of these the solutions that they've come up with. So he, just prior to talking to me, had a meeting with the FDA to get approval, because they've just developed a 3D printer to print any medication they want in space. So
To print medication.
yeah, they print the molecules in space. So
That's unbelievable.
that's the sort of technology they're working on. So.
Right. Well, you are playing with the big boys, really, aren't
Yeah.
you? That's
Well,
really...
playing, but it's big imposter syndrome, really,
Yeah.
when you're talking to people like that.
Yeah. Well, I don't know. You did you work with the growing of the human tissue?
Yeah,
So,
yeah.
you're
Yeah, I
right.
did
You're
that.
up there. You're
Yeah.
up there. I look forward to that. Hopefully that can happen for you. Now, the other thing that you are doing, which I find really interesting, is you're a little bit passionate about waste, surgical waste.
Yeah.
This was a real eye-opener for me, this thing. So do you want to maybe touch on surgical waste? This is a bit of a sort of a behind-the-scenes look into surgery, I guess, because...
Yeah, so this is an opportunity that came up last year. I was invited to do what's called a clinical innovation fellowship. So that there's a government initiative, and it was sort of a collaboration with Melbourne University in Swinburne, but they took a group of clinicians, so not just doctors, but it could be any allied health, pharmacy, nursing, physios. There was a whole different bunch of us. They teamed us up and they got us to identify a problem in our area, and they taught us the whole process of how to come up with a solution and the whole process of co-design, IP, commercialization. And at the end of it, we sort of had to develop a prototype. But the problem that I tried to solve was basically the inefficiency in the surgical processes. And when I say inefficiency, there's a lot of wasted time and money and resources. And that has huge flow-on implications. Like we've got surgical wait lists that are blowing out. So if we can better utilize our time in theatre, that would help with the wait list. But also in surgery, I've figured out probably 80% of what they open, all the equipment they open for us for surgery, doesn't get used. And that's a huge cost, both financially, but also environmentally, like to reprocess all that equipment. Some things you can't reprocess. So if I'm operating and I need a stapler and they open it and I don't need it, that's like $500 down the drain.
Or something like a stomach staple or something.
Yeah, exactly. So when we're dividing bowel or stomach, we use all these pretty neat devices that sort of staple and cut the tissue as it goes along. But
Sure.
But there is a lot of expense in surgery, and even down to the type of anesthetic that gets used. So some anesthetic agents, an hour of surgery is the equivalent of like driving 400 kilometers in a car. So it's the same sort of CO2 emissions. So there's lots of things that go on in surgery that, I'd never considered before until I sort of was forced to sort of think about it when I did this course.
Yeah, and when you were saying about that one was really interesting. So that's in the production of the anaesthetic.
Well, the production and the delivery,
Yep.
and I don't know the exact science behind it, but things like the nitrous oxide, so the laughing gas, that's a really bad one.
Yeah,
and there's
okay.
a drug called desflurane, these are the gases that you breathe in when you're asleep that keep you asleep.
Oh, okay, right, yeah.
The choice when your anaesthetist chooses which gas that they use to keep you asleep, that's got big implications on the environment.
Yeah, so CO2 emissions that's a real eye opener.
And actually, you've got
that.
an intensive care doctor locally and an anaesthetist, Forbes McGain, that's done all the work on this. So
Yes.
he's actually the professor of sustainability at the University of Melbourne. So he heads the unit at Western Hospital, just up the road.
Yeah.
Yeah.
So he's got some really interesting stuff and probably worth looking up, I think, as well.
Yeah, definitely.
So you've got, your goal with that is to reduce the waste. Let's
Exactly,
try and
yeah.
reduce the waste, try and reduce the impact on the environment and that sort of thing.
For all those reasons.
Yeah.
For the environment and also efficiency in theatre. So trying to get through the workload more effectively. So we've basically come up with a software solution to help with all those problems.
I did say earlier we were very thankful for you giving up your time generously today to come and talk to us. We were actually going to be recording this morning.
Yep.
But something come up, which is, of course, in your world, fairly crucial.
Always does.
And so you had to actually this morning do an unscheduled surgery.
Yep.
Is that the sort of thing that happens all the time?
Quite frequently. So you're sort of always on call as a surgeon. Even if you're not rostered on, because you're sort of subspecialized, if something comes up and it's in your area, there may not be necessary people around that can manage that. So you're potentially always on call. And if you operate on someone, they're your patient. So if there's ever an issue down the track, you're always on call to look after them. So yeah, it's not infrequently that you might be in all night operating on someone. It's happened quite a bit. In the last year, I've probably had 4 or 5 patients with ruptured esophagus. So I've had to go in and sort of treat that, and that can be sort of a 10-hour operation overnight. So,
Right, so marathon sort of stuff.
Yeah, but even last night, like I think I had 4 hours sleep because there's a patient who was bleeding in hospital. So that needed to be managed. So usually it's when you get called overnight, it's usually not something that can wait till the next day. So you have to sort it out then and there.
Yeah, some fairly critical sort of stuff.
Yeah.
And it's not all, we have shows on TV and that sort of thing. Sometimes you get some glorified stuff on TV, but I mean, there's a bit of I mean, the average day for a surgeon, there's some stuff that isn't a lot of fun in there as well, right?
Oh, definitely. And you don't necessarily realize that until you are a surgeon. So even as a trainee, you're not fully exposed to it or the stress of being a surgeon. You think it's fun and exciting, and it is, you get that sort of bit of a kick doing these operations, but then there's a lot of stress and responsibility that comes with it. And, not everything goes according to plan all the time. And if there are complications, sometimes it really impacts you. Like, you feel for your patient, you can't sleep for 2 or 3 weeks, you take stress home to the family. So it doesn't just impact you as the surgeon, but your whole family.
And we say there's a word that I feel like you would use a lot, and that's the word outcomes. For average Joe and Jane, the word outcomes probably doesn't mean a lot, but in your world, outcomes is a pretty big word, right?
Well, yeah, it's sort of how you measure everything and how you quantify things. And outcomes, it varies depending on what you're looking at, but an outcome might be, does someone live or die? Or it could be, what's their quality of life like? So, and the outcome needs to be representative of what's most important to the patient, I think. And it's really hard, I guess, in surgery, trying to achieve that all the time. And you have to be cognizant that maybe you're not going to achieve that all the time.
Yeah.
But you have to forewarn your patient, and you have to you establish a rapport with your patient, and there's a lot of discussion. So people, jokingly think that surgeons don't talk to patients; they just operate. But there is a lot of communication skills required.
A lot of before and after.
Oh yeah, a lot of after. Yeah.
Yeah. Okay.
Yeah. And it takes a toll as well. And as I said, that's the sort of level that you don't experience until you're actually in that position. Every time you go up a level in your medical or surgical career, you're always taking a bit more responsibility on. And it got to the point, it was probably 18 months ago, I got to the point where I thought, I should be really happy. I've ticked all these boxes on where I want to be. I've finished all my training. But I got home, I was absolutely miserable. And I was walking into work one day, and I walked past one of my colleagues who's a neurosurgeon, and he said, "Oh, how are you?" And normally you just say, "Not bad." And I said, "Oh, not feeling good, actually." And he said the same thing. And that was just a real eye-opener. And we just sort of spoke for about 30 seconds, but it was just enough to acknowledge that, it is hard sometimes. So, but yeah, you go into it thinking it's going to be all glorified and all that, but it's not always.
Yeah. You'd have some...
Because it's tough periods.
And you have to have some pretty tough conversations pretty regularly, I'd imagine.
Yeah, well, 2 in the last 2 days. Yeah.
And when you sort of talk about that, you're talking quite short, you're telling someone they don't have long to live.
Yeah, well, yesterday in particular, there was someone with an esophageal cancer quite advanced. And unfortunately, with esophageal cancer, you can only really cure them if you can operate on them. But this one was too advanced to operate, which means that they've probably only got a few months to live. So, they're difficult conversations. They never get easier.
No.
And you sort of got to tailor sort of how you let that patient know, depending on the individual.
Do they give you training how to do that?
Not really, not enough. I remember at university they got actors in, so not real patients, but actually one of the actors I had was from Neighbours, so maybe Chris Farrell knew them, but they sort of, it's really artificial. Like, you got people watching you and scoring you on how you're delivering bad news, but it's completely different. Ultimately, I like to practice, in the way that I would like to be treated, and I'd like to have people communicate with me. So that's what I mean,
what would you want? How would you want that?
Yeah, so that's and usually I find patients just want honesty. So if you're honest with them, then it sort of holds you in good stead, I think, and it keeps that rapport strong with the patient.
Yeah, it'll be a lot of trust, wouldn't there?
Oh, definitely.
Yeah,
and that's when you're early on in your surgical career, you probably don't appreciate that so much. But when you've been a patient and your whole life sort of put in someone else's hands, that's when you realize how much trust there actually is.
It's a lot, and I mean these people are relying on your expertise.
Yeah.
They're relying on you to give them accurate information, right? So
Yeah, accurate information and to try and guide them and make the right decision. Because sometimes, being a good surgeon is not just about operating, it's making the right decisions at the right time, either in surgery or knowing when not to operate. Because not everyone needs an operation, and sometimes that's a harder decision. It's easier to operate on someone probably than say, no, you don't get an operation.
because it's like action, I guess.
Mm.
When would you not operate on someone?
Oh, I can think of lots of situations, but in the cancer setting, it's if somebody's not fit enough for surgery or the tumour's too advanced.
Right.
Yeah, they're the general rules.
And they may be better off just waiting it out.
Yeah, because with operating, you don't improve their quality of life. You don't improve their survival. In fact, the tumour's more likely to sort of thrive, I guess, if you operate because you create inflammation.
Oh.
And tumour cells like that. So
Is it like giving it a massage?
basically, I'll like fertiliser on your lawn and all the weeds take off.
And then it just goes, right.
Yeah.
So that's must be a pretty hard part of the job, and it's not something that I really would ever want to be doing. So, I guess thank you for those things. Do you ever get better outcomes than you expect? Like, are you ever wrong?
Am I ever wrong? I'm probably wrong all the time, but I don't like to think I operate when I know I shouldn't. So sometimes you're forced to operate, like in an emergency situation, and sometimes, you might think something's futile, but patients might survive. That's certainly happened. And but in the sort of elective setting, when you've got time to plan things, if you think an operation's not beneficial, you wouldn't offer it to a patient. But certainly in those emergency settings, there's certainly rewarding times.
So what are your dreams for the future with it? I mean, you're doing a lot of work. You're doing work trying to have a bit of a ripple effect with your skills and abilities and access to surgical treatment overseas. You're chatting to Mr. NASA.
Yeah.
You're building some goggles. Like what do you?
I'm not building the goggles. I'm just trying to buy them.
You're going to use the goggles.
Yeah.
But what are your dreams? What do you want to achieve?
I just want to, for me personally, I just want to keep it interesting. I don't just want to do the same thing every day. I like that sort of variety. I can't just do the one operation all day, every day. Because I said at the start that a lot of things in surgery is very sort of algorithm based. You know exactly what's going to happen to a patient when they get admitted. There's not much scope to think outside the box. But I like the research stuff because you get to be a bit more creative and think outside the box. But ultimately, all those research efforts is all really just to improve patient outcomes. And we spoke about outcomes before, what that means. But it's really just to improve quality of life, really, for patients. And that's what it comes down to, because at the moment, the quality of life for a lot of the patients with the conditions we treat is really poor.
As in those particular conditions, they just don't have...
There's no good treatment options.
Yeah, okay.
Yeah. For esophageal cancer, when a patient gets referred to us, they've got a 50% chance of already having disease that's spread, which means they get palliative treatment.
Right.
So we can't cure them. They're going to die from that.
Yeah.
And if you think of all comers that come along, every patient that presents, probably only 1 in 5 will be alive at 5 years. Of the ones you treat and you think you've cured, half will be alive at 5 years. So there's lots of work that needs to be done.
And so this is where you work with the Hope Fund.
Yep.
Comes into play.
Yeah, that's to raise the money and awareness for the stuff that we're doing to try and help with those research activities.
And then the research activities themselves to actually think outside the box and try and come up with new. Yeah. Well, look, it's not like I said before. It's not something that I'd want to be dealing with on a daily basis. So I respect what you do. I mean, the scrubs that I'm wearing now is probably the closest I will get at this point.
They're actually the real scrubs.
Yeah, I know. I was just saying to you before, when I thought about where I got these, I think I might have worn these out of the hospital when one of my kids was born. So I've worn them home.
I thought it may have been a fancy dress because I recently had a fancy dress party and the theme was dress as the thing you wanted to be when you're growing up.
Ah.
and I went as a fighter pilot.
Yeah.
Yeah.
Now, I do have dabbled in a little surgery myself, actually.
Mm-hmm.
I've got quite adept at digging splinters out after a while. Although I do
Well, there's foreign bodies. You should have gone to a barber.
Oh, well, there you go. I should have gone to the barber. Well, the barber might have done a better job because I've actually got a piece of this studio still in my finger while I was building the studio. So I've got a 5mm thing that's buried deep, but it's been too long now, so it's sort of just living there now.
Wow.
So maybe after we finish this episode, I'll get you just to quickly whip out the tools, and you can do a quick. We'll clear this desk here, and you can work on it.
We'll do it in a sustainable, efficient manner.
Yeah. Look, Dr. Matthew Reid, thank you so much for coming on to the Good People podcast.
It's been a pleasure.
I wish you all the best with all.
And I wasn't as nervous as I thought I'd be.
No, you did really well. You did well. You weren't shaking.
No, you should see me with a scalpel there.
Yeah, I don't want to. I'd rather believe that you had a steady hand.
Yeah. The robot does.
Yeah, there you go. Thank you so much for coming on the Good People podcast. I wish you all the best for the important research that you're doing and for your day-to-day work. I think there's a lot of thankful people out there for the things that you do. And I also really appreciate the time that you've taken to come in, because I know that it's very difficult in between the hectic and demanding work that you do. So thank you so much for your time.
No, thanks for having me. It's been a pleasure.
And hopefully, well, maybe, when you've got the goggles going or something, when maybe we can catch up again.
Oh, yeah, we'll share an update.
And until...
Or when we get our next fellow out, you can have them on the Good People podcast.
One of your travelling surgeons.
Yeah, Lando. Hopefully he'll be here next year.
Okay.
Yeah.
That'd be a good one. That'd be great to talk to, actually.
Yep.
Well, until next year. This has been the Good People podcast with Dr. Matthew Reid. And if you're watching this on YouTube, please like and subscribe. It helps us so much. And the other thing that really helps us is if you tell your friends. Tell your friends that you heard one of Melbourne's greatest surgeons on Melbourne's best podcast.
That's it.
This has been the Good People podcast, brought to you by In Other Good News. And until next time, look after each other, take care, don't attempt your surgery at home.
Bye-bye.
Well, it's a tip of the cap, it's a pat on the back, it's a smile from ear to ear. They're the good people from round here. They're the good people from round here. Come on, let me introduce you to a few.